So I call upon the next speaker, and this presentation would be by Dr. Sanket Bhatnagar. Title of the study is Comparing Accuracy of Toric IOL Power Calculations with AS Swept Source OCT and Standard Devices.
Good evening, everyone. I'm Dr. Sanket, and I'll be presenting my study titled Comparing Accuracy of Toric IOL Power Calculations with Anterior Segments SSOCT with Standard Devices. I have no financial disclosures to make. So, with increase in incidence of astigmatism in our senile cataracts and also demand for better post-operative results, correcting astigmatism in cataract surgery has always been a conundrum for most of the phacosurgeons. So, when we have to do a precise power calculation, what we really need is a precise keratometry and biometry, which paves the way forward for our reducing SIA. So we have a big arsenal of scans in our diagnostics, of which biometry, topography, and maybe abrometry plays a pivotal role. But when we send our patients, most of which who are in the senile age group, through a battery of these scans, it can be very time consuming, ergonomically a little difficult, and also puts a financial strain on most of the practitioners. So this begs us to ask us, also COVID-19 as an epidemic has pushed us or put light on this fact that we need to go for lesser contact points and go for shorter imaging protocols. So this begs us to ask us that, is there a single imaging platform which is reliable enough to give us maybe comparable, if not a precise keratometry and biometry than our standard devices for toric calculations? So this is where Antirion by Heidelberg comes into picture. It is a multimodal imaging platform for anterior segment optimization, which uses highest resolution swept source OCT with 1300 nanometer wavelength, which gives us a longer wavelength or a scan depth and low scatter. It combines topography and tomography with biometry and also has a eye tracking technology, which gives us faster acquisition time. And there is a provision of using Oculix, which is a ray tracing software, which gives us more accurate results. So a single machine gives us biometry, topography, is used as an anterior segment OCT and also as an inbuilt toric IOL planner. But can it replace our standard topography and biometry devices? So we conducted our study with the purpose being to compare reliability and agreement of parameters which were measured between Antirion, IOLMaster 700 and Oculizer. We also compared the residual corneal astigmatism post-operatively, which was achieved by Antirion toric planning and by the toric planning done by conventional devices, and assessed the mean prediction error post-operatively. So in our study, which was a prospective interventional study, 42 eyes of 32 patients between 50 to 75 years of age with acquired senile cataract and astigmatism of more than 1 diopter with normal corneas and no other ocular pathology underwent clear corneal phacoemulsification by a single surgeon, where a temporal 2.2 millimeter incision was made and a toric monofocal aspheric IOL was implanted. So pre-operatively and post-operatively at day 30th, all the patients underwent visual acuity, manifest refraction, and detailed slit lamp examination. Both IOLMaster and Antirion were used to measure mean keratometry, astigmatism, pachymetry, axial length, and biometry. We gauged the mean keratometry, astigmatism, and pachymetry through Oculizer. Coming to toric planning, biometry and topography from Oculizer and IOLMaster were used, and Alcon online toric calculator was used to calculate the IOL power and the cylinder which was residual. Parallelly, Antirion was used to do the topography and biometry, and the inbuilt toric calculator was used with the same A constant and formula that was used. Now, through the conventional devices, whatever power was calculated, Acrisoft IQ toric lens was implanted based on that. Now, coming to the results, in our sample size of 42 eyes of 32 patients, mean IOL implanted was plus 23.52 diopters, and there was a statistically significant change in visual acuity, residual corneal astigmatism, and mean spherical equivalent pre and post operatively. Now, coming to or surveying the or surveying the repeatability, intra-class coefficient correlation was used, and Antirion showed moderate to good repeatability for most of the parameters with excellent repeatability for axial length. Most of the parameters that were measured, which were mean preoperative astigmatic power, keratometric values, axial length, and pachymetry, had no statistically significant difference in variability. Also, the bland almond plot showed good to excellent agreement between parameters measured by Antirion and IOLMaster, particularly for axial length. So to gauge the accuracy of toric planning in the conventional devices, an anterior mean prediction error analysis was done, which was measured as a difference between the actual residual astigmatism and what was targeted. And though there was no statistically significant difference, anterior showed a lesser mean prediction error. So what we knew was that predictive accuracy of toric IOL power calculation depends on precise biometry and keratometry, and there are multiple biometers and keratometers at hand, and a composite workup on these is required for toric power calculation. But in this study, what we have seen is anterior gives us moderate to good repeatability for most of the pivotal parameters that we have, and has good agreement with IOL master for biometry and also topography. Also, it has lower prediction error in toric calculation compared to toric calculation with conventional devices. So to conclude, based on this study only, Heidelberg anterior with its longer wavelength and larger penetration depth can be used as a single platform for imaging and biometry and keratometry for toric power calculation. But this study was not without its limitations. It had a smaller sample size and the follow-up period was only 1 month post-operative. Also, the toricity of IOL implanted were not considered, which can be a confounding factor. And vector analysis is still, we are looking for more sample size, so it's in the pipeline, and maybe in the future we'll be presenting the vector analysis where we can see the change in diopter and axis pre and post operatively. Thank you.
Sir.
Yes.
So your comparison was with IOL Master 700.
Yes.
Right. Now COVID is over.
Yes.
Whether you can still calculate within a, because everyone doesn't have an one machine. You know, I mean, if you have an say 2 machines or 3 machines, you have an a topo, you have an say swept source biometer, and then still you feel that the results.
So we can still reduce the burden of machines in our diagnostic scans. So if anterior is reliable enough by only IOL master, which can be, we are still not very sure that it is giving as good or reliable parameters at pentacam. Lot of people are going with pentacam and oculizer still for topography and astigmatic power, sir. Plus it has a toric planner inbuilt with Oculix, sir. So maybe.
Okay. Now the second question comes.
Yes, sir.
Have you any comparison of an anterior with an Argus?
With, sir?
With Argus?
No, sir. We don't,
because that is proved to be having a better keratometry than.
So we are collecting data because it's a prospective study. We have to maybe have a longer follow-up also, sir, with these machines also.